Hello everyone, we are going to talk about part 2 of respiratory system, which is respiratory function. Mechanics of breathing involves pulmonary ventilation that consists of two phases. Inspiration is gases flow into the lungs, and expiration involves gases exit lungs. Pressure relationships in the thoracic cavity involves atmospheric pressure, which is 700 millimeter mercury at sea level, equals 1 atmosphere. Respiratory pressure described relative to atmospheric pressure, and negative respiratory pressure is less than atmospheric pressure, and positive respiratory pressure is greater than P atmospheric pressure, and zero respiratory pressure is equals atmospheric pressure. Intrapulmonary pressure is pressure in alveoli and fluctuate with breathing and always eventually equalized with atmospheric pressure. Intrapleural pressure is a pressure in pleural cavity and fluctuates with breathing and always negative pressure. Negative intrapleural pressure is caused by opposing forces. Two inward forces promote lung collapse, and they are elastic recoil of lungs decreases lung size, and surface tension of alveoli fluid reduces alveoli size. And on the other hand, one outer force tends to enlarge lungs, and elasticity of chest walls push thorax outward. Pulmonary ventilation involves in inspiration and expiration. Mechanical processes that depends on volume change in thoracic cavity. They are like volume changes, pressure changes. When pressure changes, gas flows to equalize pressure. Boyle's law describes relationship between pressure and volume of a gas. When gas fill container, if container size reduced, that increase the pressure, and pressure varies inversely with the volume. Inspiration is an active process. Inspiratory muscle, such as diaphragm and external intercostals, contracts, then thoracic volume increases, and intrapulmonary pressure drops below -1 millimeter mercury, and lungs stretch, and the intrapulmonary volume increases and air flows into lungs down its pressure gradients until pulmonary pressure equals atmospheric pressure. Expiration is a normally passive process. In quiet expiration, here inspiratory muscles relax and thoracic cavity volume decreases, and elastic lungs recoil, and intrapulmonary volume decreases, and pressure increases to +1 millimeter mercury. Therefore, air flows out of lungs down its pressure gradient until pulmonary pressure equals 0. This slide shows you the first line up here, pink color, intrapleural pressure change during inspiration and expiration. As you see, pressure inside the lung decreases as lung volume increases during inspiration, and also pressure increases during expiration. And this purple line in the middle shows intrapleural pressure change during inspiration and expiration. Pleural cavity pressure becomes more negative as chest wall expands during inspiration and returns to an initial value as chest wall recoils. And also bottom parts with blue shows volume of breath. During each breath, the pressure gradient moves about 0.5 liter of air into and out of lung. Airway resistance and alveoli surface tension and lung compliances are three factors that hinder pulmonary ventilation. And basically it requires energy to overcome these three factors for lung to have ventilation. So airway resistance is a friction, so that major non-elastic source of resistance to gas flow that occurs in airways. Airway resistance is basically very insignificant and in large airway diameters in first part of conducting zone. However, it progressively branching of airways as it gets smaller, and it increases total cross-sectional area, and so resistance greatest in medium-sized bronchi, and resistance disappear at terminal bronchioles where diffusion drives gas movement. Let's see, and also airway resistance rises as breathing movement become more strenuous, and severe constriction or obstruction of bronchioles cause that life-sustaining ventilation, and that normally occurs during acute asthma attack, and that needs quite a bit of help. And second is alveoli surface tension. It's caused by surfactant that is like a fat, like a lipid, and made by type 2 alveoli cells, and basically it reduces surface tension of alveoli fluid, and it discharges alveoli collapse. If you do not have enough of this surfactant, as you probably heard about premature infant respiratory distress syndrome, and so they die right after the birth. And third factors are lung compliances. It's a measure of change in lung volume, basically. So if you have a higher lung compliances, means that it is easier to expand lungs. Normally, due to high stretchability of the lung tissue, and however, if you have scar tissues in a lung, you have a very low lung compliances. That means it's very difficult to stretch the lung. Respiratory volumes are used to assess respiratory status. So tidal volume, TV, inspiratory reserve volume, IRV, expiratory reserve volume, ERV, residual volume, RV, respiratory capacities. So those are the respiratory volumes are measured, and also combination of respiratory volumes are inspiratory capacity, IC, functional residual capacity, FRC, vital capacity, VC, total lung capacity, TLC. And dead space is basically anatomical dead space, has no contribution to gas exchange, and air remaining in passageways. So those are about 150 milliliter. Alveoli dead space normally designate non-functional alveoli due to collapse or obstruction. So basically total dead space is equals sum of anatomical and alveoli dead space. Functional pulmonary function test can be measured by spirometer, and that is the instrument for measuring respiratory volumes and capacities. And this spirometry can distinguish between obstructive pulmonary disease. In that case, you will have increased airway resistance, such as bronchitis, and so TLC, FRC, RV may increase. Restrictive disorders shows reduced TLC due to disease or fibrosis, and VC, TLC, FRC, RV decline. So basically, pulmonary function test is to measure rate of gas movement, and forced vital capacity, FVC, is the gas forcefully expelled after taking deep breath, and FEV, forced expiratory volume, is the amount of gas expelled during specific time intervals of FVC. Alveoli ventilation is a minute ventilation, and it measures total amount of gas flow into and out of respiratory tract in 1 minute, and normally the value is about, at rest, about 6 liters per minute. External and internal respiration involve physical properties of gases and composition of alveoli gas. Dalton's law of partial pressures explains total pressure exerted by a mixture of gases is the sum of pressures exerted by each gas. Partial pressure means a pressure exerted by each gas in mixture and directly proportional to its percentage in mixture. Henry's law describes gas mixtures in contact with liquid, and each gas dissolves in proportion to its partial pressure. Composition of alveoli gas shows in the top graph. Alveoli contain more CO2 than atmospheric air, and gas exchange in lungs occurs. Internal respiration involves capillary gas exchange in body tissue, and partial pressures and diffusion gradients are reversed compared to external respiration, and the tissue PO2 is always lower than in systemic arterial blood, so diffusion of oxygen from blood to tissue occurs, and carbon dioxide from tissue to blood occurs, and venous blood PO2 is about 40 millimeter mercury, and PCO2 is about 45 millimeter mercury. External respiration involves exchange of oxygen and CO2 across respiratory membrane and influenced by thickness and surface area of respiratory membrane and partial pressure gradient and gas solubilities and ventilation perfusion coupling. Here, just briefly say that thickness of respiratory membrane is about up to 1 micrometer thick, and which is about 40 times that of skin for gas exchange. And if it thickens, it becomes very difficult for lung to participate in gas exchange. And we see these things in the case of emphysema and tumors and inflammation. And as you see here, partial pressure gradient is in the case of oxygen in lungs is a lot bigger, because PO2 shown here in venous blood is about 40 millimeter mercury, but alveoli PO2 is 104 millimeter mercury, so that drives the oxygen flow to blood. In the case of partial pressure for CO2 in lungs is less stiff, and venous blood PCO2 is 45 millimeter mercury, and the alveolar PCO2 is about 40 millimeter mercury. However, PCO2 diffusion occurs because CO2 solubility is about 20 times more than the oxygen solubility. Let's say another thing that I want to just mention briefly is the perfusion and ventilation coupling. That means perfusion first is the blood flow reaching alveoli, and ventilation is the amount of gas reaching alveoli. So ventilation and perfusion has to be matched or coupled for efficient gas exchange. And in order to do that, perfusion changes in PO2 in alveoli cause changes in diameter of arterioles. Where alveoli O2 is high, arterioles dilates. Where alveoli O2 is low, arterioles constrict, and it directs most blood where alveoli oxygen is high. And changes in PCO2 in alveoli cause changes in diameters of bronchioles, where alveoli CO2 is high and bronchioles dilate. Where alveoli CO2 is low, bronchioles constrict, so therefore it allows elimination of CO2 more easily. Oxygen transport involves molecular oxygen carried in blood. It's about 1.5% are dissolved in plasma, and most of 98.5% are loosely bound to each hemoglobin of ion of the hemoglobin in red blood cells. And 4 oxygen per hemoglobin is possible. Oxyhemoglobin is hemoglobin and oxygen combination, and reduced hemoglobin is called deoxyhemoglobin. It's a hemoglobin that has released oxygen. So unloading and loading of oxygen is facilitated by changes in the shape of hemoglobin As oxygen binds, hemoglobin affinity for oxygen increases. As oxygen is released, hemoglobin affinity for oxygen decreases. As you see this at the tissue, partial pressure of oxygen is about 40 millimeter mercury. About 75% of oxygen is bound to the hemoglobin, and at the lung of partial pressure of PO2 is about 100. Most of hemoglobin are bound to oxygen. So let's look at the effect of temperature and PCO2 and blood pH on oxygen hemoglobin dissociation curve. That means normal body temperature, shown as a purple line, that the percentage of oxygen saturation of hemoglobin are shown. As you see that if you decrease the body temperature, as you see this oxygen saturation is left shifted. That means that more oxygen can be bound tightly to hemoglobin. And however, if body temperature is raised up 43 degrees, as you see in a red line shows that oxygen saturation is lower. If you look at the 40% saturation, and PO2 is a lot lower. Partial pressure is lower in the higher temperature versus in normal or lower temperature. And also, in the case of if you increase the proton concentration, in other words, if the pH is becoming the lower, as shown in a red graph, on the right side of the normal graph of the purple, as you see, less oxygen is bound to the hemoglobin, therefore more oxygen is released to the tissue where active metabolic reaction occurs. And also, if you have higher pH, that means less amount of CO2 is released, because it's a slower metabolic rate of the cells. That means less oxygen is released to the tissue. In other words, that blue line shows the tighter oxygen binding to hemoglobin of the red blood cells. So these are called BOA effects. CO2 is transported in blood in three forms. As you see in the top, oxygen release and carbon dioxide is picked up at the tissue level. About 7 to 10% dissolved in plasma in CO2, and about 20% is bound to globin of hemoglobin as carbamino hemoglobin, and rest of the 70% of the CO2 is transported as a bicarbonate ion in plasma. And as you see, that transport and exchange of CO2 involves CO2 has to combine with water to form carbonic acid, which quickly dissociate. And this occurs primarily in red blood cells, where carbonic anhydrase enzyme reversibly and rapidly catalyze this reaction. And then transport and exchange of CO2 occurs in systemic capillaries, and this bicarbonate ion HCO3- is quickly diffuses from the red blood cell into plasma. These are called chloride shift, and then this is sort of balanced out by having chloride into red blood cells and out of bicarbonate ion, so that charges can be balanced. Let's see, and then as you see that at the lung, where red blood cell now reverses those reactions we saw in the upper figure. As you see that when it reaches the lung, you have to regenerate the H2CO3 from chloride is out of the red blood cell, and then bicarbonate ion in a plasma gets into the red cells. These are called chloride shift, which is the reverse. And then that bicarbonate ion now will pick up that hydrogen ion
okay, which is basically removed from hemoglobin, yes, by releasing, by bound to oxygen to hemoglobin, let this hemoglobin to go with this hydrogen ion, which will now combine with the bicarbonate ion to form carbonic acid, and then this enzyme, carbonic anhydrate in red blood cells, will reverse back to CO2 and then H2O. So the CO2 in the red cells will be higher, so it's going to be diffused out to the alveoli so that you can breathe out. And also, some part the CO2 dissolved in the plasma can be diffusing out directly to alveoli. And also, some of the bicarbonate remain in plasma can bond with the hydrogen ion and forming the carbonic acid. And that also reverses back to CO2 to water. And so CO2 can be diffused out as well. At the same time, oxygen you breathe in the lung alveoli can now diffuse into the red blood cell, where now, as I said earlier, it will bound to hemoglobin. This is how the proton can be released from hemoglobin, which can be now available for bicarbonate ion, which came from the plasma to bound together to form carbonic acid. Okay, so this is how transport of and exchange of CO2 and oxygen in the lungs and at the tissues occur. This slide shows the control of respiration involves the higher brain centers and chemoreceptors and other reflexes. As you see, that neural control involves the neurons in reticular formation of medulla and pons, and basically ventral respiratory group and dorsal respiratory group and medullary respiratory centers are very important in terms of controlling these activities. And as you see that also, they have to work with a diaphragm through phrenic intercostal nerves, and also medullary respiratory centers actually involved with this, and also pons also participate in this rhythm, and also depth of the breathing. Generation of respiratory rhythm is not very well understood. However, the factors influencing breathing depth is normally determined by how actively respiratory center stimulates respiratory muscles, and breathing rate is determined by how long inspiratory center is active, and these are modified by your demands of your body's demands. And also, most important factors are changing levels of CO2 and oxygen and hydrogen ions, and these are sensed by central and peripheral chemoreceptors, as you see. This slide shows you if you build a partial pressure of CO2 or a drop in pH in your blood, it will be sensed either by a chemoreceptor, which is a central chemoreceptor, or peripheral chemoreceptors, and then they will innervate the afferent neurons through medullary respiratory center, which will actually give innervation of motor neurons to respiratory muscles, which is intercostal or diaphragm, so that your breathing rate will be much deeper, so that you will be more likely breathe out CO2, so that you can go back to arterial PCO2 is going to be lower and pH will be rise to the normal level. So this is done by negative feedbacks that we've been talking about all these semesters.